All right, so maybe we'll get started. I always play this interesting game of either 50 attendees or 1203. I'm not sure how I've come up with that criteria, but we're 1203 and we're almost to 50 people. So I know people tend to trickle in over the course of the first 10 minutes. So welcome to the 22nd annual conference hosted by the Center for Clinical Ethics, and thank you so much for joining. Of course, we've changed our format this year, and if you've joined us for previous weeks, you'll see that we're offering more of a seminar series versus sort of a single day full conference, which is what we used to do. While the Center for Clinical Ethics is based at Unity Health Toronto, we also provide ethics services to 6 other healthcare organizations representing over 4,400 beds. So I'd particularly like to welcome those who are joining from Lakeridge Health, Scarborough Health Network, Waypoint Center for Mental Health, Runnymede Healthcare, Toronto Grace Healthcare, St. Joe's Hamilton, and of course, Unity Health Toronto. I'd like to begin with a land acknowledgement. I'd like to acknowledge the land on which we gather is the traditional territory of the Haudenosaunee, and most recently, the territory of the Mississaugas of the New Credit First Nation. This territory was subject of the agreement between the Iroquois Confederacy and the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. This territory is also covered by the Upper Canada Treaties. Today is still home to many Indigenous people from across Turtle Island, and we are thankful to have the opportunity to work in the community on this territory. It is our collective responsibility to recognize this land as traditional territory. With gratitude, we say miigwech, to thank the Haudenosaunee, Mississaugas, and other Indigenous peoples for taking care of this land from time immemorial and for sharing this land for those of us who are newcomers. Out of this gratitude, we are called to treat the land, its plants, peoples, stories with honor and respect. So the theme of this year's conference, our seminar series, is Confronting Injustice, Exploring Ethical Issues Raised During COVID-19. We know that COVID has further amplified social inequities, and over the past few weeks, and then again on this week, we really have been trying to shine a light on some of these issues. So today I'm privileged to introduce Dr. Ross Upshur. He was a professor of mine when I was doing the MHSC in bioethics, and it's a real treat to have him here today. He'll be speaking about ethical issues in the COVID-19 pandemic, local and global perspectives, our lessons ever learned. Just a little bit about Ross. He's the head division of clinical public health at the Dalai Lama School of Public Health and the assistant director of the Lunenfeld Tannenbaum Research Institute at Sinai Health System. At U of T, he's a professor at the Department of Family and Community Medicine and the Dalai Lama School of Public Health, adjunct scientist at the Institute for Clinical Evaluative Sciences and an affiliate of the Institute of History and Philosophy of Science and Technology, and a member of the Center for the Environment. He's a member of the Royal College of Physicians and Surgeons of Canada and the Family Physicians of Canada. Ross, thank you so much for sharing your wisdom with us today, and I'll hand over the mic to you. The format's going to be about 45 minutes of discussion or of you presenting, and then we will have a chance for some Q&A, and that will be done in the chat section, so no one will have their mic. Excellent. Thanks, Ross.
Thank you, Michael, and thank you to the Center for Clinical Ethics for the privilege of coming to speaking to you today. I hope everyone in the audience is doing well, staying safe, sane, being good to yourself and to others. So in the next 40 minutes, I'm going to try to compress a few thousand years of human experience and 2 decades of research on ethical issues related to epidemics and infectious diseases. And the pandemic, if we think of the etymology of the term pan and demos, people, this pandemic has truly affected each and every one of us in a multitude of ways. It's exposed our vulnerabilities, the fractures in our systems. And we've tried to respond fairly compassionately and effectively in the context of incredible complexity and uncertainty. So it's not surprising then that many ethical issues arise, and what I'll argue is that pandemic response is fundamentally and quintessentially ethical in its nature. One of the key issues here, starting right from the beginning, is that we're victims and vectors alike. In other words, because of that communicable nature of the disease, we are vulnerable in a pandemic. None of us at the beginning have any immunity to it, so we're all able to be infected. And of course, one of the gifts of giving when you become infected is the transmission to others. And in fact, if we think of our own lives, we've all done this. Any parent has been infected by a child and passed it along to someone else. So it just illustrates some of these deep human issues. I'm going to start with some disclosures. I have I get some grants from CIHR, PSI. I've had honoraria from Jewel. Consulting fees from G2P2. I'm an employee of Sinai Health and the Dalai Lama School of Public Health, and relevant to these deliberations, though I will not speak on behalf of the organization, as I'm co-chairing the World Health Organization COVID-19 Ethics Working Group. I don't have any conflicts of interest, but I often have conflicts with interests, and so we'll go on. And this is my omnibus apology slide. So it just says, if you can't read it, I just want to apologize beforehand if you miss. So being a good Canadian, I want to apologize if I don't cover an issue or a topic that you're interested in. I'm particularly interested in not wasting your time, so if I do, I apologize for that. If I quote the wrong theorist, I apologize for that as well. So we can come back to this. If I don't know the answer to your question, I'll apologize now. So the objectives, I want to talk about ethical issues as they arise in the context of pandemics, and some of the key ethical issues that have arisen globally and locally during COVID-19, and then maybe talk about some potential solutions and why ethical frameworks may be required as a way forward. So I'm going to start in the distant past. I'm going to move to the recent past. I'm going to do some critical reflection on my experience over 20 years. So I've been involved in SARS here in 2003, in pandemic preparedness discussions in the aughts, in the H1N1. I've also worked with the World Health Organization on Ebola and Zika, and now SARS-CoV-2. So I've seen this sort of thing before, and I want to distill some of my thoughts into what I call as the pandemic playbook, and then maybe talk about some future-oriented ways of thinking. I want to start with a couple of quotations from Albert Camus' The Plague. And early in the pandemic, I was encouraging people to read this, but I don't anymore because we're kind of living the plot as it unfolds. But he makes two interesting observations. He says, everybody knows that pestilences have a way of recurring in the world, yet somehow we do find it hard to believe in ones that crash down on our heads from the blue sky. And a year ago, we weren't thinking at all about pandemics. We went into December 2019 blissfully unaware of what was starting to unfold in China, and then seemed to crash down on our heads from the blue sky. He further notes that there's been as many plagues as wars in history, yet they always take us equally by surprise. And one of the lessons I want us to learn is that we ought not to be surprised anymore. And I'll reinforce that point as we go through. So this is just a time series graph of the famous 1918-1919 influenza pandemic, and it's a mortality graph, and it illustrates a few points. One is the sudden explosiveness, and actually SARS-CoV-2 is not behaving quite like this, but we're seeing these secondary and tertiary waves, or like in the US, this kind of stepped up wave. But you can imagine the disruption, and we know the disruption that a mortality rate of 6% in a week would cause, how disruptive that would be to the function of society, the sheer amount of grief that would be in the community, the dislocation and the disruption. And you can see it happens at different points of time in different places, and we're seeing that certainly with SARS-CoV-2. But if we go back even further in history, so in Thucydides' history of the Peloponnesian War, he has a description, quite an interesting description of what was called the Plague of Athens. And to this day, epidemiologists still debate what the causative organism would be. He makes this observation that neither were physicians at first of any service, ignorant as they were of the proper way to treat it, but they dyed themselves the most thickly as they visited the sick most often. Nor did any human heart succeed any better. Supplications in the temples, divinations, and so forth were found equally futile till the overwhelming nature of the disaster at last put a stop to them altogether. So we're not very much different from the ancient Athenians. When SARS-CoV-2 first emerged, we didn't know how to treat it. And in fact, an illustrative point that recurs in epidemics literature is that those who are first responders, or those who are involved in intimate care relationships with people who are sick, are the ones who are most likely to become infected. And if it's a particularly fatal illness, such as Ebola, contract the disease and have a high risk of dying. We also know that communicable diseases are intensely stigmatizing, and we've seen various themes of stigma associated with SARS-CoV-2. This is a picture of the leper. The leper is in a particular garb. They're gowned, they've got a hat on, and they carry the Lazarus bell to ring and a clapper to make noise so that when they come into the presence of anybody, they can turn their backs on them and not engage in any interaction. And this is the so-called prayer of separation. I won't read it out to you, but if anybody has any doubt about the relationship between very strongly normative ethics and infectious diseases, you would take note of all of the I forbid, I forbid, I forbid, I forbid, I command, I forbid statements. And you might start to resonate with some of these because you're forbidden to enter any tavern if you wish for wine. You're not allowed to share a house with anybody but your wife. And these kind of prohibitions are very similar to what we're seeing now in public health messaging. You have to stay in your bubble. You can't go into a store. So there's nothing new about what we're experiencing, but it's not particularly targeted to any one disease group. If we move forward in history, we see the same story in the Plague Diaries by Defoe. The plague was defying all medicines. The very physicians were seized with it. Men went about prescribing to others and telling them what to do, and they dropped down dead, destroyed by that very enemy they directed others to oppose. And even the skillfulness of the physician did not save them. So the same recurring issue of those who come to the aid of those who are sick become sick themselves, often with fatal outcomes. And we innovate. So this is a picture of a fumigation box as a treatment for syphilis. I illustrate it just to say that whenever there's an infection, we're looking for a treatment. And we'll come back to this notion of fumigation and smoke as we go through history. And this notion of separation. This is a picture from a newspaper in the late 19th century here in Canada when there was a smallpox outbreak. So the idea here is that the best way to control the outbreak would be to actually seal off the hospital that has all the patients, maintaining that separation, keeping the infected away from the uninfected, as if this is going to have some sort of causal efficacy. And again, back to stigmatization. This is a picture of a gentleman in Ellis Island. He's got tuberculosis and therefore will not be able to enter the United States. So we have this long tradition of fear of contagion, of this notion of stigmatization, of this belief that separating the sick from the unwell will help bring control. And we now know in the 20th century that, in the 21st century, that social and physical distancing, isolation, and quarantine may often be the only tools we have, and that they do actually work. But we need to figure out how to do that in a compassionate and ethical manner. So I'll come to the future, or to the recent past, SARS in 2003, 17 years ago. And this is just a picture of the medieval plague doctor. I'm sure everybody's seen it. It's been around a lot now, so it's not so novel. But you can see gloves, gown, mask. The pointy stick is for exploring buboes. So bubonic plague, buboes are large lymph nodes filled with pus, and they get confluent. So buboes are quite large, matted growths in the axilla and groin. And the reason for the pointed beak is to put a poultice in there, because ventilation systems in the Middle Ages were rather primitive and buboes can be rather aromatic. SARS was supposed to be the great global wake-up call, and look at the headlines from 2 major news magazines. What's the truth about SARS? Have we been hearing? What's the truth about COVID? Why does the virus spread? Is China covering up? How scared should we be? And what do we need to know in the new age of epidemics? And of course, we had the same issues. This is the modern garb of a physician preparing to go and care for a patient with SARS. If you take away, there's no pointy stick, and we have plastics, but really the techniques are the same: mask, gown, glove. After SARS, we were concerned about H5N1, which was a highly pathogenic strain of avian influenza, and people started to think about pandemic preparedness, and many organizations started doing pandemic flu preparedness. It was thought in the worst case scenario that about 1.6 million Canadians could die in a catastrophic flu epidemic. And of course, the species that fared poorly were chickens, because avian influenza tends to find a very successful breeding ground in poultry stock. And this is a picture taken at the border between Bulgaria and Romania, I believe, when a case of highly pathogenic avian influenza was found. And I like to joke, the only people at risk are these 2 guys. Who knows what's in that fog, but they've got these flimsy paper masks, and I've never actually seen a bird hitchhike on top of a train. We didn't get a highly pathogenic H5N1 influenza. We got H1N1, so-called swine flu, distant relative. Its distant relative being that H1N1 influenza that was responsible for the 1918-1919 influenza outbreak. And of course, there were concerns. Swine flu spurs Canada to stock up on ventilators. We don't have enough ventilators. What are we going to do? And there's a lovely picture of Alison McGeer, for those of you who know her, as a very well-known microbiologist at Sinai Health. So there was all sorts of concerns about whether we had enough ventilators, and we were going to have to ration ventilators. When there was a death of an unfortunate death of a teenager in Toronto with H1N1, there was all of a sudden a pent-up demand for vaccine, long lineups. And this resonates with the lineups that we saw for testing when people were concerned about getting tests for COVID. And there was, of course, the usual post-mortem, and André Picard wrote a very insightful piece, as usual, talking about if this situation to arise again, maybe a novel influenza virus, maybe a coronavirus, as it may turn out, emerging where Canada and countries where Canadians travel in high numbers, high mortality, what would we do? And he said it would be hard-pressed to see if we would do anything different. So he said we spent a lot of money, and we still did the right thing. And I hope when all is said and done with COVID-19 that we can come to that same conclusion. But the school is out on that still. I want to spend some time just a little bit about Ebola to sort of draw these parallels. So Ebola was declared at the time one of the greatest threats to global security by the United Nations Security Council. It now seems a relatively small outbreak in comparison to COVID-19, but we still see the same echo. We need major cooperation for global security. Sierra Leone introduced a lockdown, a 3-day lockdown. It was the first time in modern history where a true lockdown was put in place. They did it so they could go door to door for case ascertainment, because there was concerns that cases were hiding in the community. And of course, lockdown has now entered our day-to-day vocabulary. And this use of restrictive measures, this top picture is taken at the entrance to a neighborhood called West Point in Monrovia, Liberia. Monrovia is one of the poorest cities, and Sierra Leone is one of the, or pardon me, Liberia is one of the most highly disadvantaged countries. And the president decided to basically keep people inside of West Point. And if you Google map Monrovia, you'll see this little peninsula, which is West Point. And of course, there was understandable pushback, and there was violence and death at this barbed wire fence. And we see similar echoes of keeping streets empty and people inside in this outbreak. Pandemics also have a habit of bringing out some of the less savory dimensions of human behavior, in this case, black markets. In the Ebola outbreak, it was rumored that blood of Ebola survivors promoted health and prevented you from getting ill. Those familiar with the history of West Africa know that it had quite a considerable and protracted civil war. There were still gangs and factions who would actually capture known survivors and tap them with blood for sale. And this hampered the ability to actually create survivor cohorts to figure out what the long-term sequelae of Ebola disease are. And we see the same sort of black markets forming around the world, including someone in British Columbia selling black market masks. And of course, there's consequences. People who recovered from Ebola were afraid that the virus would return, and we're seeing suggestions of that in COVID survivors. We all look forward for the day when it's over. And so we need 2 incubation periods to declare an outbreak over. So for the Ebola, it was 42 days. For COVID, it will be probably 28 days. But sadly, you can't will the end of a pandemic. And we've seen many places, South Korea, Australia, New Zealand, bring things under control only to have it recrudesce again. And we'd be remiss in not mentioning MERS, which is another coronavirus, and Zika. And so here's my first point. You know it's a serious event when the foggers come out. People start fogging buildings, you know that there's something serious going on. So do we learn lessons? So very quickly after Ebola, there was a flurry of papers on, Ebola pushed us to the limit. We've got to learn lessons. For the next epidemic, lessons learned from Ebola, Bill Gates had access to both the New England Journal of Medicine and the New York Times op-ed column to talk about lessons and how we need to prepare for the future. However, if you were looking for lessons learned from our Canadian experience, you would be hard-pressed to find them because you can see that they've been archived and you can't easily access the lessons learned from H1N1 or the lessons learned from SARS. And we should wake up. It's a wake-up call. So SARS was a wake-up call, and H1N1 swine flu were wake-up calls. And if you Google search wake-up call or lessons learned for SARS-CoV-2, you'll get about 458 million hits. And so our question with a colleague, former doctoral student of mine, Max Smith, this was me getting grumpy during Ebola, like, haven't we heard these lessons before? Doesn't this all ring strangely familiar to you? So we thought that the most important lesson we must learn from Ebola outbreak regards our inability to learn lessons from past outbreaks. And Max and I have updated this paper for COVID. It's almost like, as I said, we either have collective amnesia or collective narcolepsy. We need to relearn things, or we keep falling asleep and we need to be woken up again. And so we've published a more detailed account and analysis of this in the Journal of Public Health Ethics back in 2015, and we updated it this summer in a special thematic issue in the Journal of Bioethical Inquiry. And I recommend, you don't have to read that paper, but there's some excellent papers. They're very short and brief and very insightful, and I can send a link to Michael for people who are interested, or you can just search it. So what's the pandemic playbook? What am I talking about here? So on the left side column, I've identified what are sort of characteristic events in the life of an epidemic, and on the other column, the associated ethical issues. So since the time of Thucydides, and probably before, there's high early morbidity and mortality in healthcare providers and caregivers. This inevitably raises questions around the duty to care and the duty to protect. In fact, in the aughts, I was co-chair of a panel for the World Health Organization on health workers' obligations in pandemics. And, you know, this raised its head in H1N1. It was certainly there in Ebola. Do healthcare providers, are they obliged to care for people when they themselves may become ill? Are they obliged, if there's not reciprocal protection in the form of personal protective equipment given from health systems? And once again, with SARS-CoV-2, you hear the same thing. I didn't sign up for this. I didn't know I could get infected. And I've been arguing for 15 years that when we're training and recruiting and admitting people into the health professions, they ought to know this. This ought to be in our codes of ethics. It ought to be front and center, because what I'm going to argue is these sorts of events are no longer exceptional. If you go back to 2003, SARS, H1N1, Ebola, Zika, MERS, SARS-CoV-2, 4 of those are public health emergencies of international concern. They're happening more and more frequently. We can't be taken by surprise, as the Camus quotation tells us. The other thing is that if we don't know how to treat things, if we have no medical countermeasures, there's high levels of uncertainty, we need to engage in research in order to clear up and close those evidence gaps. This puts research ethics front and center as incredibly important. Part of the work that we've done with the World Health Organization is to reinforce that there's no such thing as pandemic exceptionalism. Simply because there's a public health emergency does not mean that you derogate, abrogate, overrule well-established principles and concepts in human subjects research. And the interesting thing at the WHO R&D Blueprint meeting in February is that all of the funders, Gates Foundation, NIH, Wellcome, and the WHO itself reinforced this point. No shortcuts. So all of you researchers out there, get off the backs of the REBs. They're doing their best, but you have to abide by the same rules. We'll find ways to be more nimble and responsive, and I'll speak to some of those documents. In the absence of effective medical countermeasures, we're going to need to use public health measures. Those involve things such as quarantine, isolation, mobility restriction, contact tracing, and surveillance. And all of these raise fundamental issues around public health ethics, and people have to start to think about, well, and you can see this again in the discourse, who are you to take away my rights, you know, just because it's a public health emergency. And then I have to remind people that the reason we have public health law, the reason why we have over a 100-year tradition of having things like municipal health units and medical officers of health, is that they have the obligation, like a clinician does to their patient. They have an obligation to protect the community from the spread of communicable diseases and avert and prevent preventable illness. And of course, we'll face scarcity. And once again, do we have enough vaccines? Who's going to get it first? Did we have enough PPE? How are you going to allocate that? And of course, the thorny issue of critical care, ventilators, and triage. Again, these have all been visited before, and they're being visited again as if we'd never seen them before. And the global issues. How much of a global player are we? How much cosmopolitan commitment do we have? Is it truly a pandemic in which it's not over until everyone is protected? Or are we going to be happy with kind of a vaccine nationalism strategy? You know, we've got enough for ourselves, and to heck with the rest of the world. Global equity is not something that we're going to be concerned with. So these 5 issues have been evident in each of the outbreaks that I've studied. And of course, there is an abundance of guidance documents to consult when facing these issues. But the big question is, why don't people connect with this? And, you know, I've sadly, he says in retrospect, I've worked on many of these documents. And the one I'm particularly happy with, though I didn't participate in it as an external reviewer, is this Nuffield Council on Bioethics. They get the award for the most timely publication. If you see the date on that, 28th of January 2020, it came out. They've been working on it for years. And of course, that was the same week that the public health emergency of international concern was declared, and there they were with a guidance document on research ethics and global health emergencies. So there's an abundance of thinking that's been done, but I think it's a characteristic of the ethics community that only the ethics people know about this. Broader health system policy planners, policymakers, clinicians are unfamiliar with this work. And of course, with colleagues, we've contributed an abundant amount of reflection and research to the literature on almost every one of these topics. And so with the World Health Organization, there's a few interesting nuances to COVID-19, things like digital proximity tracking technologies, the use of apps, how individual level can you get with the data, issues around, for example, human challenge studies. They've been around for a while, but we put out a guidance document on this. The two ones on guidance, one is an SOP for committees doing rapid review of research during public health emergencies, and then a distillation of all of the existing research ethics guidance to support COVID. There's been some interesting stuff on herd immunity, on immunity passports. So those are kind of the new additional wrinkles from COVID-19. So should we have been prepared for this? And the answer is not just ethically, but scientifically. So when I first entered public health in the early 90s, it was around the time that the Institute of Medicine in the US released its report on emerging and re-emerging infectious diseases. And you can see there at the bottom is a timeline. So remember, famously or apocryphally, the Surgeon General of the US said in the late 60s that the war on infectious disease, it was time to close the book on infectious diseases, the big challenges in cancer and chronic diseases. And you can see from that bottom chart just the very large number of newly emerged or re-emerged pathogens. You can see from the map the fact that the emergence of these diseases is global. And you can see that they've been well characterized and categorized. Furthermore, there's this first initial Institute of Medicine report had this schematic, sort of a causal diagram of how all of these factors interrelate. And you can just basically drag and drop SARS-CoV-2 into this diagram because all of these different elements are featuring. Demographics, travel, air travel, technology, commerce, a highly, highly interconnected, interdependent global economy. The movement into zoonotic pools, human encroachment into animal territories and into reservoirs through economic development and land use, which brings us into contact with zoonotic hosts, which brings us into contact with a microbial population, which comes into humans and spreads. So all of this was well known, well characterized, and people in the public, not just in the public health and infectious disease communities, have been trying to alert policymakers and others to take this seriously and be prepared. And again, you know, here's the headlines. Do we have enough ventilators? Can we make quarantines mandatory? What about, can we track people? So these are the kind of ethical issues. And it's moving so fast, you know, you start to think about what you're going to do in the vaccine space, and 2 weeks later, you're in a different place. Maybe we can come back to that. And of course, the foggers have been out in abundance. Again, I think it's just something that people like for the visual, because now, of course, everybody is saying, you know, there's really not a lot of contact spread. But man, we are avid sprayers when there's a pandemic happening. So now just to sort of drill into a little bit more depth on the ethical reflection and thinking. So how are we going to get out of this? One of the things that frustrated me early on was the seeming inability of policymakers to declare and state clearly what the goals of pandemic response would be. You know, we got into a bit of meme science on, well, we're going to flatten the curve. Why? Well, because we want to save the healthcare system. And you say, well, isn't the healthcare system there to help people when they're sick? And now you've pushed it into the community, and now people are still anxious about contacting the healthcare service because they're good Canadians and they want to spare the healthcare system. So what is the goal? Are we trying to control spread? Are we trying to reduce morbidity and mortality? Because once you've got your goals set, then your strategy will follow. And what values should guide this process? Who should articulate them? Should they be exclusively, you know, autochthonous, local? Should we be only concerned about ourselves? It's not a pandemic. It's a series of, you know, micro epidemics that we're kind of moving in that direction, as you can see, because each province, each municipality is facing this in a very different way. And what concerns should we have if it's truly a pandemic of global scope? How do we take what resources we have to contribute and aid others who have less resources to do this. What are the ethical hazards that need to be negotiated? Who has the authority to make these decisions? And what are the consequences for failing to address them? And I've already pointed out the conspicuous failure of preparation. I hope I have persuaded you that we should have been abundantly aware of all of these possibilities. So yes, ethical frameworks help. They help provide a moral compass during a public health crisis. That was the key message in that Nuffield Council report. It's abject scientism to believe that you can bootstrap your way out of this empirically, because you need to have some sort of values and some sort of guiding principles to allow you to move. And difficult decisions will have to be made, and it needs to be clear who's going to make them, how they're going to make them, and when they're going to make them. And they're going to be, this is slides taken from my old pandemic influenza presentations, because they're still germane today. It's going to be, we need to be guided by ethical decision-making processes and informed by ethical values. Now, one of the chief problems, as I alluded to at the outset, is the sheer complexity of trying to understand what's happening in a pandemic. You need people who understand microbiology and immunology, and genomics and virology, and all of that knowledge, all of our investments in fundamental science. People say, wow, we got a vaccine quickly. Actually, we didn't. What we did was we invested over the decades in bench science, and people started to understand RNA and messenger RNA and the technology. So it was years and years and years of science that we were able to capitalize on, so that we could sequence the virus and then apply biotechnology to develop vaccines. But had we not made that investment, we wouldn't be in the position we're in today. But we also need the human sciences, and epidemiology is kind of nicely in the middle. There's social epidemiology. It's a very quantitative discipline, but it kind of sits between social sciences and mathematical sciences. We need law, we need psychology, we need zoology, anthropology, geography. We need to think about in a very integrated way, drawing on a large number of disciplines to make sense of a pandemic. And we also have to integrate ethics at a variety of different levels. So a pandemic isn't a purely public health ethics issue. There's very deep issues in personal ethics, and each one of us has been going through that reflection. Am I going to adhere to these public health things? Am I going to put somebody at risk? Clinical and professional ethics. I've already alluded to issues around duty to care. Organizational ethics, how organizations are going to respond to how they manage the possibility that they will have large numbers of people exposed within their walls. What kind of sick policies? What kind of leave policies? How do we deal with the complexities that each and every one of you are dealing with, managing your own lives, your family's lives, and your professional obligations, and how do our organizations facilitate it? And of course, there are issues in public health ethics that I alluded to on that balancing between individual liberties and public health goals, and I've already alluded to, issues in global health ethics. So we need to think about this across multiple levels. And so some of the key ethical concepts we've articulated in some of our work. So this notion of reciprocity, which I'm happy to speak of in multiple different ways. So on the public health side of things, it's all fine and good to ask people to stay home or to close their business in order to achieve public health goals. But there's also requirements on those making that request to provide as much support to enable people to discharge their obligations to public health. Reciprocity also plays out in the kind of policies we have for sick leave. We have a general obligation not to infect others if we can help it, but we have to find ways to make sure that discharging that obligation is not overly burdensome. Trust is a huge normative concept. We did a lot of thinking about trust around H1N1. Trust and trustworthiness. And for those who are interested, a colleague, Alison Thompson, did a very good presentation at yesterday's Joint Center for Bioethics rounds on the role that trust and trustworthiness plays in addressing vaccine hesitancy. And another colleague, Maya Goldenberg, has written a fabulous book on vaccine hesitancy and trust. It's not a knowledge deficit, it's an issue about trust and trustworthiness of institutions and the kind of behavioral things that institutions and organizations need to do to assure themselves of that trust, that they're in fact trustworthy. These notions of common good arguments. So public health is not something for any one individual, it's something that we hold in common. So our obligations when we discharge into public health aren't for our own self-regarding well-being, though they may be a convergence between our self-interest and our other regarding interest in adhering to public health guidance. This notion of precautionary principle played a huge role in the aftermath of SARS. In fact, the Campbell Commission argued that public health or public policy and decision makers ought to have been more precautionary in their approach to managing the pandemic, which would have meant assuring the protection. I've alluded to solidarity. How do we appropriately communicate risk? And this focus on the relational nature of humanity rather than focused on autonomy and liberty rights. So we tried to capture all of this in our framework in 2005. I was pleased to see it reborn in other frameworks that were being presented by national ethics committees in their COVID response at a meeting of the national committees, bioethics committees that the World Health Organization held. So these substantive values we articulated. Our research went to do confirmation with communities, with various different public engagement methods. And you can see the ones there in bold are the ones that I think are really specifically important. And then there's, of course, the procedural issues about how you make decisions, that they're fair, transparent, accountable. You're working to negate power imbalances. I haven't addressed specifically issues of equity and the inequitable distribution of risk in populations that we've been aware of. We've got a whole separate talk on that. Maybe some future day we can have a discussion. And again, these key concepts emerge: community engagement, you have to go, you have to listen, trust, I've mentioned, solidarity and reciprocity, these gluey principles, these things that indicate that we're in this together. It's not just something that we're facing individually. And of course, one of the key issues in public health ethics is this notion that public health stands to improve the health and well-being of all, but also with specific focus and interest in those who are most disadvantaged. And one metric of looking at the response is to ensure that those who are disadvantaged by whichever form of intersectional disadvantage, structural or otherwise, have not been made worse off by the pandemic response. And that's part of the evaluative obligations we have to ensure that that didn't happen. And if it did happen, we figure that out and redress that. So my last slide, it's a bit of a cheeky, this is not a picture of Sergei Korsakov, this is in fact George Santayana. Everybody knows his famous quotation, those who do not remember the past are condemned to repeat it. Sergei Korsakov is a Russian neurologist who discovered, first characterized what's called Korsakov syndrome. It's a situation in which usually through high consumption of alcohol, you're no longer able to process short-term memory. So you're incapable of learning new things and you forget, and so you confabulate and make things up. And I think sometimes that we have kind of a collective Korsakov syndrome when it comes to pandemics, and I'll close where I started. These things will recur. It will seem like they've come out of the blue sky. It will take us by surprise. But my argument is we would be remiss if the next one, and there will be another one, if it takes us by surprise. A coronavirus, a little tiny virus, ought not to bring the global community to a halt. It did, and it ought not to happen again. And I will stop there and thank you for your time and attention.
All right. Thank you so much. I mean, I guess maybe one difference between this pandemic and others in the past, like H1N1, is the global reach. So maybe the fact that everyone has been affected will help prevent Korsakoff's, although.
Well, we'll see, because, you know, people are telling me we won't forget this time. I'm going, okay, yeah, maybe we need the equivalent of a poppy, right? We should have a pandemic remembrance day, so that we can, you know, and the same motto, lest we forget.
Right.
Yeah.
Which might makes the Veteran Affairs people a little bit upset with us, but
we'll partner with them. It's a common good argument.
All right, so I had a question from Erna that actually wants to know whether you would be willing to make slides available.
Yes.
And so if you send it to me, I can make sure that anybody who requests it can get access to it. Just a reminder, we also are recording the session. So if you wanted to hear the commentary that goes along with the slides, we'll make that available on our website. So we've got, and again, please feel free to write in your questions in the Q&A box. It's not the chat box, it's the Q&A box. And I'm happy to read this out, or Ross, I see.
Yeah, why don't you just, okay. It might make it easier, then I can just focus on thinking.
So
I'm getting old, I can't read and think at the same time.
It's very difficult to trust the COVID vaccines when they skip proper double-blind trials and testing. It's understandable that so many people don't want the vaccine, but people are sick of wearing masks, so they might take a chance for normality. Do you personally agree with mandatory vaccinations? If you feel comfortable to share or not. If not, I respect your privacy. So.
Oh yeah, no, I'm happy to talk about this. So first thing is most of the trials are at least single-blinded, and some of them are double-blinded. I would recommend two resources to look at if you want to know about the vaccine trials. One is the New York Times Vaccine Tracker, and there's a scientist, Hilda Bastian, who has a blog on PLOS, where she's keeping a very close watch. She's very astute, but one of the virtues of her blog is she has a link to all of the publicly available protocols. So if you're really interested in the vaccine trials and you want to know about their primary endpoints and their secondary endpoints and their statistical analysis and their consent forms, she has about 12 of them on that website. So they are double-blinded. The issue now is the trials are sort of complete. It's kind of hard, even though I'm actually working with the World Health Organization. The only thing we know about these vaccines is what's been in the press releases, and the WHO actually just said, you know, we don't want to do science by press release. We know the regulatory authorities have the data and they're looking at it, because they're looking at what are called emergency use designations. That is, short of full licensure, which gives marketing authority, it's a way of getting something out while information is still coming in. And there's a big debate. You might want to look at the New England Journal of Medicine today. There's an editorial from the WHO about continuing the placebo trials with people in their assigned case, because the manufacturers have argued that they're obliged to break code on the basis of these interim analysis and offer up the vaccine to the placebo group, which means you lose insight to all the safety signals. Now, to the issue of mandatory vaccines, it's really important to unpack what's meant by mandatory. So mandatory does not mean compulsory. And in fact, we do have a back history, and I got a whole presentation on this too, because I've done a lot of thinking about this over the years. So we used to have, in the 19th century, in the UK, in the US, and in Canada, compulsory or forcible vaccination against smallpox. An interesting side story here is that the first conscientious objection laws ever in the British common law tradition arose out of what's called the Leicester anti-vaccination movement. And this is interesting historically, because the hygienists, people who believed that, remember that Victorian ideal of cleanliness being next to godliness, they were arguing that vaccinating people alleviated the responsibility to behave in a sanitary manner. And they were all in, so it's kind of contrary. Now modern public health has both sanitation and vaccination side by side, but about 150 years ago, they were at odds with each other. They started to stage protests against compulsory vaccination. They went on hunger strikes, and the British government decided that it was unwise to basically imprison citizens who are exercising their good conscience. They put in the conscientious objection clause, and that carried forward over to Canada. So compulsion of vaccination is not possible. Mandatory in the sense of conditional is definitely ethically permissible, and we have it, for example, for the health professions. There is no right to be a physician. You have to be educated, you have to be certified, you have to be licensed. And healthcare organizations have decided that we shouldn't be in the business of spreading illness to our patients, which is why, as a condition of employment, we insist that you have certain vaccinations in order to practice. So we're not forcing you to take it. You can exercise your choice not to practice in this particular organization. And even if you look at for example, the Immunization of School Pupils Act in Ontario, it's not mandatory vaccination. It's if you don't vaccinate your kids, then we won't let them into school when there's, you reserve the right not to vaccinate your child. We reserve the right to exclude your child if there's an outbreak. So it's really important to tease apart what we mean by mandatory, because it's certainly not compulsory. And interestingly enough, I don't think you could ever have compulsory vaccination in Canada, though you could in the United States, because Jacobson versus Massachusetts in 1905 found that it was not a limitation of fundamental rights to require vaccination to prevent a public health disaster. So I think so mandate becomes kind of a lightning rod term where people think that the government is going to override some sort of rights that they hold dear to themselves. And as I've said to a lot of people in the last few weeks, please go read the Charter of Rights and Freedoms and look at the language about Canadian rights and freedoms and how they're protected, and how there's language in there that counterbalances. There's kind of a communitarian thread in there, the capacity to override those for certain public health goods. And there's also an excellent textbook on public health law in Canada from the University of Alberta that nicely outlines all of the different laws and powers of public health, including the emergency powers, which I think all educated citizens in a time when we're being governed under emergency, we should know about. So I'm not sure if that answers your question or not, but it was my best. I wasn't afraid to try. But thanks for it's a great question, a really important question.
And there was one follow-up to that was around the actual the sites that you referenced. So I found the New York Times link, and I put that in the sort of the answer section. You mentioned like
her name is Hilda Bastian.
Okay, that was her then. Okay,
it's Bastian, and I just came across that recently because I was desperately looking for the protocols, because it's really important when we're talking about allocating vaccines, and people are going crazy about 95% efficacy, which I'll point out is a point estimate, and there's uncertainty around that. But it's really important to know what that efficacy readout is, and it's any symptomatic COVID infection. It's not mortality, it's not severe disease, and the reason why they're reading out faster than others is because it's the most permissive endpoint. There's a lot of serious questions we need to ask about the vaccine, and I'm the furthest thing from an anti-vaxxer or a vaccine hesitant person. But that doesn't mean that you suspend your critical thinking when we're making incredibly important policy decisions.
Agreed. Okay, I'm going to go through a couple of other questions. One was, I think Dr. Paul-André Gauthier was next. Okay, so it looks like it's a bit of a fragment. So I guess he says, I believe that out of these two, first come, first serve, duty to protect, first as healthcare provider, then as duty to care for others. It sounded more
so that might be on allocation principles. Yeah. So it's interesting. we've just done, actually, my colleague Max Smith, who I mentioned, has just got a small grant to look at vaccine allocation principles that have been articulated for the COVID vaccines. And another one of our colleagues, Angus Dawson, did similar work for influenza vaccines. And so this is looking at the Institute of Medicine, World Health Organization, a National Advisory Committee on Immunization in Canada. And there's this great table of all of the different populations and principles that are being invoked, and they're quite varied. But the important thing is that any allocation scheme needs to be explicitly articulated, and the value and tied to values, like why, what undermine. So if you're interested in protecting the most vulnerable, again, this goes back to my point about what are the goals of the response and being clear about that, then you would be concerned with those populations who are disproportionately affected by COVID-19. And we have a lot of experience with the disease. We know it preys upon older, vulnerable populations and populations who suffer from structural disadvantage. So if you're going to be evidence informed, you would, on the risk, you'd want to target those populations. But that's not the entire story. And this goes back to my concern about efficacy endpoints in vaccines. If the vaccine is ineffective in older adults, if that's what the data shows, and we're going to have very uncertain strata-specific estimates, because even though these are large clinical trials with 30,000 people in it, the endpoints, they were powered to be finished after 200 exposures. So you just think, 200 infections divided by 15,000 people in the intervention and 15,000 in the control group, you know in advance you're going to have wide confidence intervals on any age-specific protection. And again, if the efficacy endpoint is any disease and you're interested in mortality and severe disease, I can tell you a priori, we're going to be constrained in our ability to determine whether the vaccine achieves those goals. And so if you're going to deploy a vaccine where it's not going to be effective, that would be an ineffective way of allocating scarce resources. You may need to come back and say, what about if it's most effective in younger populations, why don't we ring vaccinate around the vulnerable? But we're going to have to make those decisions very nimbly, still dealing and navigating with some uncertainty, but the arguments should not just say the data shows this, they should identify the goals, the values, and link those to the empirical strategies.
We have another follow-up from Franklin Wagner, and he says, Ross, given that the veneer is now off on extremely negative impact of the pandemic on the mental health populations, and presumably those who will require new mental health services, do the same ethical principles for decision-making apply, or are others needed for extremely vulnerable populations?
That's a fantastic question, Frank. And earlier this morning, I was on an international call and listening to social sciences talk about the very extensive mental health consequences of COVID-19 and how it's showing up in populations that were hitherto not considered to be basically affected by the pandemic. So youth and adolescents, apparently there was a report, I think, I haven't read it yet, on the mental health impact in Canada. Do we need new ethics for that? I'm not sure. I'd be certainly happy to sit down and have a discussion with you about that. I think sort of principles of reciprocity, solidarity, building trust would help us to mobilize resources for concern for that population. But I would certainly be open and interested to hear your thoughts on that for sure. Deferring to your considerable expertise.
Maybe time for just one last one, if I can sneak this one in. And this is about influencing people's behavior. So while it seems clear how to manage COVID-19 at the population level, we're not doing such a great job influencing individuals to comply with needed behavior. Is there a strategy for enlisting their cooperation?
Yeah, that's another super question. So one of the interesting additions to that whole WHO research and development blueprint. Historically, they've taken a fairly classically biomedical approach. And sometimes when I'm at meetings, I think that the epidemic is happening either only at the cellular level or in the intensive care unit. But we did learn something from Ebola, and that was the overarching importance of social sciences and engaging with communities and deploying social science to help us understand what's motivating and stimulating behavior. So I think there is promise there. The WHO has invested in social science research. It will entail that we get down to the street level. We need to understand and engage with communities at the level of the community and the neighborhood to understand the information that's being passed around. One of the other things that differentiates this pandemic from others is the inordinate and oversized influence of social media on formulating people's beliefs. And the simple fact of the matter is most public health agencies and government agencies are not savvy, flexible, and nimble in their use of social media. And people who are interested in misinformation are exceptionally good at it. So I think that's an excellent observation, and I think that would be my response to that suggestion.
Thank you, Ross, and thank you for, I know you've got lots of competing interests and priorities, and thanks for making time with us today. We had about 80 people join, which is, I think, pretty good given all the constraints and everybody's time. So thank you so much.
My great pleasure. I hope it was of some use and benefit. And everybody, as I said, take care, be well, and be safe. And hopefully we'll be through this sooner rather than later.
Agreed. And I also want to thank the people that are behind the scenes. So Mark Kanash, that has done has been excellent in sort of in terms of organizing and making sure that all the speakers had all the correct links and really handled all the IT back-end stuff greatly. The mailman is here, so my dog is now barking. Wanted to thank Linda Sullivan for, again, a lot of the behind the scenes stuff, certainly members of my staff, particularly Rochelle Maurice and Sean Hillman, that were very helpful in terms of trying to identify some of the previous speakers, all the speakers over the last 3 weeks, and of course, all of you that have joined us. So just to echo what Ross just said, please stay safe, please be well, and hopefully together we can get through this. Have a great afternoon, everybody.
Thanks again. Bye-bye.
Thanks, Ross. Bye.